Welcome, everyone. Thank you for attending. This is a co-organized World Federation of Public Health Associations and the European Society of Gynecological Oncology. And it's good that we're working together because the title of the webinar is really important. It's Advancing HPV Immunization, a life course approach with a focus on adults. There are three key issues that we want to highlight today. The scale of the opportunity is enormous. HPV-related cancers claim hundreds and thousands of lives every year. They're largely preventable, and vaccination is the most powerful tool we have to address this. The second point is the importance of co-organization. Today's webinar is co-organized by the World Federation of Public Health Associations and the European Society for Gynecological Oncology. This partnership reflects the need for public health ambition being matched by clinical and oncological expertise. And so we're grateful for ESGO for their leadership and their co-organization of this important event. The third point is framing to the call to action. WFPHA has issued a call to action on HPV adult immunization, and today's webinar is part of the implementation phase for that call. Our goal is not only to share evidence, but to mobilize public health community to act in policy and in practice and in advocacy. So welcome again to this seminar and a few housekeeping calls. The session is being live streamed on the WFPHA Facebook page, and it will be recorded and made available on our YouTube channel in a few days. There's a Q&A section at the end and following the presentations. And if you have any questions, can you put them in the chat, please? And I'll try to raise them with our speakers. But I want to say thank you very much to our three presenters. We have Bettina Bosch, who is well known to the public health community as the CEO of the World Federation, but also in her own right, an expert in cancer and women issues. We have Dr. Nancy Durand. Nancy is a global health specialist at the Clinton Health Access Initiative, focused on HPV vaccination and cervical cancer prevention programs. Their work supports governments in low and middle income countries to expand access to HPV vaccinations, strengthening screening, treatment services, and improving women's health systems. CHI's cervical cancer initiatives emphasize affordable HPV testing, community-based screening, and integration with HPV and reproductive health services to reduce preventable cancer deaths. Nancy, welcome. Then we also have Dr. Elmer Jura. Elmer is an associate professor of gynecology and in the Department of Obstetrics and Gynecology, Medical University of Vienna. He graduated from the University of Graz, Austria, and subsequently worked in the Department of Pathological Anatomy. After internship in neurology, surgery, and internal medicine, he started his training in obstetrics and gynecology at the University of Vienna. Before he finished specialization, he worked for a period in Tanzania. So thank you all for being involved in this webinar. And Bettina, can I hand over to you to address the WFPHA call to action on HPV adult immunization and life course approach?
Thank you, Raman, and it's an absolute honor and pleasure for me to be together on one screen with Nancy and Elmer. It is a perfect collaboration. I am here for the public health voice, and without the voices of clinical specialists like Nancy and Elmer, we wouldn't be able to do our public health programs. And I would like to say that public health needs the evidence and the data and everything that you will see from both of them in their presentations right now after my introductory words. This is one important part of public health, to know, to have the evidence. But as I like to say, implementation is key. And when it comes to implementation, we are always a bit weaker. Implementation, if we go for groups of people, needs the people and their views. The people may be individuals and individual politicians and individual people somewhere in a workplace, but we address whole a group. And here, with our call on adult immunization and life course, we even call on people for taking care of an issue like HPV throughout life. So it's a very important implementation process. And our individual views and decisions are very heavily influenced not by evidence, but by conception and maybe by old inherited views. And this holds true for all of us. It is difficult to be free of things that we have in the back of our mind. And we have seen how important this is in vaccination itself, how views that we cannot, let's say, document with real data have influenced or destroyed vaccination campaigns. I show you this picture here. It is from Durand, Albrecht Durand, 1476. It is to be found in the British Museum. And there are different interpretations of this picture. It says 4 women in a bath house or 4 women in a brothel. Why do I show this picture? At that time, we are early Renaissance. It was clearly thought that men who had sex with so-called she-devils will later on suffer from illness and impotence. Even earlier on in medieval times, the sexually transmitted diseases were always depicted as female figures. And we should not think that this has completely disappeared. Even public health campaigns in the 19th century used this kind of, let's say, framing. So we call it sometimes misconception, we call it stigma, but never forget that if we want to implement a program, we have to take care of the views of people that should be the ones taking up, for example, a vaccination, and who should take up and why should take up. If it comes to vaccination, and there is another aspect for public health implementation, and this is a moral one. We know that with HPV, with vaccine type HPV, we are able to eradicate several cancers, several deadly cancers. And we could call this a common public good, like fresh air, fresh water, and clean air. We have the ethical, let's say, moral need to do it because we can do it. And there is another thing. If we consider vaccine type HPV a common global good, then, and if the market doesn't do it, it's a clear call on public health agencies and on public health intervention to do what has to be done to eradicate lethal diseases. Means for public health authorities to assume this obligation as a kind of implicit contract. And economists have clearly shown, in addition, that if we only have an inadequate commitment to the eradication strategy, we will have at the end, also from the economical standpoint, long-term public implicit liability. Because also from the economics standpoint, to eradicate is the best option, and to eradicate throughout life course and in so-called neutral or all gender vaccination is the best option. So the World Federation has done our view with a scoping review that we just have published. We wanted to look at recent evidence on the effectiveness of vaccination among adults. Just among adults, you will have clinical data, very good data also on what happens vaccination after people having been treated for cancers by ALMA. We had a scoping review on what exists actually, and we looked as how effective is adult vaccination by looking at several criteria: infection, the precancerous lesions like CINs 1 to 3, prevention, and the number of HPV-related cancers, as well as the benign endogenital warts occurrence. And what clearly has been coming out of the scoping review is there is protective and therapeutic effect of HPV vaccination on HPV infection and related diseases outcomes among adults. And the countries that have already done a lot, and here I have something from Sweden, can also model in what happens in the future. And here we have a Swedish modeling exercise, number of HPV-related cancers with and without catch-up vaccination, and what happens over time. So you see that you can, if you vaccinate from 17 to 30, no vaccination here, vaccination there, get less number of cancers. Here is the absolute number of cases. It's a model, but you see that if you go longer than young adulthood or school, you will add up number of cases that are prevented. So in terms of pure public health, the evidence is there. You will hear about more other evidence later on. And that's why the World Federation has, one of the reasons, put up the call to action. We want to maintain a clear focus on HPV elimination, HPV vaccine-related HPVs. We want to position this adult vaccination, which in some countries will add up to school-based programs, in a clear public health hierarchy. And as public health measures, a lot of countries do have organized screening programs. Pap smear is one of the very well-established programs. Where there is such an organized screening program, we think it's wise to integrate vaccination. So we use an existing program to add up another one, because the screening program usually goes for adults. And I put it in really very, very simple things. Why universal vaccination? Universal meaning both all sexes and ages. Why is it matters for long-term cancer prevention? Very shortly, in adults, and you will see how important that is from Nancy, remain at ongoing risk. Again, our views in society and on an aging society have to change. even adults above the age of something may have a sexual life, you know. There are some conceptions that lead to views. And what is very clear for HPV now in most places, men are disproportionately underserved. The conception has been also due to the existing vaccination screening programs, it's young girls. And if we want to end transmission, we have to address the whole viral reservoir, men and women, girls and boys. And we have data that vaccination works even after exposure, a question that comes back very frequently. We know that the public health outcomes are significant. And we also know that the current frequently used school-based, age-restricted fundings leave a lot of people behind who never had the chance or the possibility to get vaccinated during school, for example. And very importantly, if we go for programs, vaccination must be easy to access. And we have good examples in countries where this access has been facilitated, for example, through pharmacies and pharmacists. And we think that we have to have this call because we need a consensus on adult vaccination very dearly. And we know that a faster elimination is achievable, as some countries show it recently. And this is extremely good news. And with this being said, I would like to thank you for your attention from Geneva, from the lake, and our JETDO. Thank you, and back to Raman.
Bettina, thank you very much. That was tremendous. Nancy, we look to you now to speak to us on HPV female and male adult vaccination. Thank you.
Thank you so much, Bettina, and thank you so much, Ram, for allowing me to join today. So what I'm going to talk about is the evolving science, and it definitely is evolving, as we have mentioned, with respect to HPV vaccination. These are my disclosures. So we know that the annual global incidence of HPV-related cancer is extremely high, and in fact, HPV is now known to cause at least 5% of all cancers globally. And if we look at low and middle income countries, of course, they bear the highest cervical cancer incidence globally, with 94% of the annual deaths around the world from cervical cancer. And of LMICs, the highest incidence is, as we can see, in sub-Saharan Africa, Central America, and Southeast Asia. The risk factors for cervical cancer, as we know, are HIV, gender inequality, as Bettina mentioned, and poverty. And then if we turn to high-income countries or high-resource countries, we have seen over the past several decades the declining incidence of cervical cancer, mostly due to screening in women, declining at about 2% per year, plotted against the rising incidence of oropharyngeal cancers caused by HPV in males. And we see that the curves have actually crossed in high resource countries. So we could say certainly that in those regions, what was thought of as really a female cancer is now at least gender neutral and is even tipping towards becoming an issue more for males. The WHO announced their global strategy in 2018 for the elimination of cervical cancer as a public health problem, and their definition for elimination was to attain cervical cancer cases to be less than 4 cases per 100,000 women in a geographical region. And the targets that they set by 2030, which really isn't that far off, was that 90% of girls should be fully vaccinated by the age of 15, that 70% of women should be screened using a high-performance test at least 2 times during their lifetime, and that 90% of women with cervical disease should be treated for precancers and cancers. And what's good news is that almost 200 countries and regions, territories around the world have either national or regional HPV vaccination programs. And more than half of these are what we call universal, meaning gender neutral, including both boys and girls. So that's the good news. The problem, though, is that global HPV vaccination rates amongst adolescents remains low. And as of 2024, by the age of 15, only about 30% of girls, and even lower, 7% of boys had received at least one dose of HPV vaccine. So the majority of individuals still remain unvaccinated, and there is a need to catch up those who missed out on HPV vaccination. This leads us to the question of why might we consider then adult HPV vaccination? Well, we all know the best practice is that we vaccinate before the onset of sexual activity, meaning in adolescence, but the reality is many regions have been later adopters of national immunization programs, and we still have lower coverage rates in many regions of the world. Of course, there is the issue of equity that many may not have had access to those national programs based on their age or even based on their gender. So when we turn to adult HPV vaccination, we can think of this really in two different ways. We can think of this as a public health goal and the benefit to the population. So here we would be filling in the gaps in those lower vaccine coverage rates in national programs to help us accelerate the path to elimination, including those who didn't qualify. And by doing that, we could increase herd protection. And think of this as a multi-age cohort rationale where we would have adolescents and young adults included in vaccination. And then we also, as clinicians, want to think of the individual protection to that person or patients sitting in front of us. So there is benefit to adults, as we will see, for HPV vaccination. As an adult, they do have risk of exposure. There is efficacy to vaccinating adults, and there's safety. And is it really our job as a healthcare provider to provide the patient with the most up-to-date information and the opportunity to be vaccinated so that they make the best informed decision for themselves? If we look at the prevalence of HPV, meaning the chance that you have an HPV infection at any snapshot in time, we can see on the left panel that in women, HPV prevalence gradually declines with age, but it doesn't decline to zero. So prevalence at age 50 is still pretty high at 35%. And then if we see on the right-hand side, prevalence in males is even higher than in females and does not decline with age. Prevalence is about 65%, as seen in the HIM study. So sexually active adult females and males do remain vulnerable to HPV infection, diseases, and potentially cancers throughout their lifetime. And it's the persistence of HPV infection that can lead to certain cancers and other diseases. Now, we may think that we're not at high risk if we're in a monogamous relationship, but in fact, this may not be true. That newly detected HPV infections can occur in the absence of new sexual partners, especially the absence of new sexual partners that you know about. There may also be those that you don't know about in your monogamous relationship. Now, we use modeling predictions to help us understand the age of causal infections for those people who have developed disease. So, for example, in modeling, 50% of women diagnosed with cervical cancer are predicted to have acquired their causal infection after the age of 23. And even more in the case of males with oropharyngeal cancer are predicted to have acquired their HPV-16 infection after the age of 20. So most adults, we might think, have already been exposed to all the types of HPV, so there's no point in vaccinating them. And in fact, that's not true. The majority of adults have not been exposed to all types covered by the 9-valent vaccine, meaning that almost all patients will have some benefit to the types they have not yet been exposed to that are protected by 9-valent vaccine. We do face significant challenges. Most people think HPV vaccination is just for adolescents, and people includes patients and also includes healthcare provider attitudes. Most adults aren't aware that HPV is associated with cancers beyond cervical cancer. And the knowledge is significantly lower, specifically in adult males compared to adult females. So we have work to do. We do face barriers. There's certainly the stigma attached with a vaccine against the sexually transmitted diseases. And people in monogamous relationships believe that they have decreased risk. And as I mentioned, there is insufficient knowledge, and there's often a lack of recommendation by us as healthcare providers. So, what is the clinical evidence for vaccinating adults? The original clinical trials randomized younger adults up to the age of 26 to vaccine or placebo, and as you can see, excellent reduction of cervical disease and external genital lesions. But we also have evidence now for adult women up to the age of 45, almost 90% reduction of cervical disease, vaginal vulvar disease, and external genital lesions. That was with quadrivalent vaccine, and the 9-valent vaccine also showed excellent efficacy in the younger adults. And then bridging trials show excellent antibody response in older adult women, which then bridges down to the efficacy already proven in younger women. What about the men? Men in the younger male vaccinated trial showed almost 90% reduction of external genital warts when compared to placebo groups, and 75% reduction of high-grade anal disease. And again, bridging trials were used to look at the efficacy of the antibody response in older males, which was non-inferior. And again, for 9-valent vaccine, we have just recently received evidence from Japan that shows more than 90% reduction of persistent infection in young adult males. So very encouraging, the long-term clinical trials. But we do want to follow people after the original clinical trials, which usually lasted approximately 4 years. And a cohort of the younger women trial continued to be followed and have now been followed out to 18 years. And they show no breakthrough cases of disease caused by those original vaccine types. The older women trial also is now published out to 10 years, showing no breakthrough cases. And the 9-valent trial now published out to 14 years. So we look to all of these long-term follow-up trials to help show us excellent durability of these HPV vaccines, that efficacy continues and that antibody response continues. We can also turn to the real-world impact that vaccination has had, and many of you are familiar with the Australian data showing significant reduction in external genital warts extremely early after the onset of their national immunization programs. A very impressive reduction of the first effect that you're going to see from a vaccination program. But we also have now seen reduction in high-grade cervical disease, the precursor for cervical cancer, as shown in this study from Scotland. And in the work from Sweden, of which Dr. Dillner's been involved, we have seen excellent reduction now in the long-term data, followed now out to 18 years, in reduction of cervical cancer. And here we compare those who were not vaccinated to those who were vaccinated. Of course, we see the best reduction when we vaccinate people under the age of 17. But what's very interesting is we now also see reduction of cervical cancer in those vaccinated after the age of 17. Similar results have been shown in England with reduction of cervical cancer and high-grade cervical dysplasia, and in Scotland as well. If we turn not just to cervical disease, but also to oral HPV prevalence, studies from the United States and the United Kingdom have shown decreasing oral HPV prevalence in those who are vaccinated, and in the United States, we are seeing dropping oropharyngeal cancer cases. Excuse me, I'd like to turn to the HPV faster strategy, which was proposed now more than 10 years ago by Xavi Bosch's group. HPV faster pertains to us continuing adolescent HPV vaccination programs, but linking adult HPV vaccination to the cervical screening visit. That we should have at least 1 or 2 cervical screens during our adulthood. How has this come into practice? Well, first we can look at the Swedish example, which is HPV Even Faster Elimination Project. And here we are continuing the adolescent gender-neutral national immunization program, which had excellent uptake rates. Sweden has now turned their attention to primary HPV testing for cervical screening instead of Pap testing, and have transitioned now from provider-based testing to offer home-based HPV testing. Sweden links that cervical screening test with the offer of adult HPV vaccination. What Sweden did to say even faster was to target those at highest risk for HPV transmission. And this was the individuals aged 23 to 30 who had not originally been included in the national immunization program. And Sweden offers concomitant HPV vaccination and screening, which has achieved the goal of trying to eliminate cervical cancer, not by 2030, but to bring that goal down 3 years earlier to 2027. Now, we may all think that that's only achievable in high-income countries, and we should look to Rwanda, a lower-income country, who is also looking to achieve faster elimination of cervical cancer and HPV infection. Rwanda has a history of very successful vaccination program, and they are now offering in this project concomitant HPV screening and HPV vaccination. 100,000 women between the ages of 23 and 29 in rural and urban areas will be offered HPV vaccination at the same time as HPV testing. And the observed rates in high-grade dysplasia and cervical cancer will be compared to the general population rates, and they also have reduced their goal of elimination of cervical cancer by 3 years to 2027. So as we see, screening is an opportunity to vaccinate, but vaccination is also an opportunity to screen. Sweden started with an excellent cervical screening program already in place and added HPV vaccination. Rwanda started with a successful vaccination program and then added cervical screening. So it can be adapted to the region in which we live. We should not assume that young adults, female or male, were already vaccinated in national immunization programs, because we know vaccine coverage rates are certainly not optimal. And remember that as we counsel adults about HPV vaccination, these adults are now the parents of children or may become the parents of children in the future. So we will have a dual benefit. When we vaccinate adults, we will also help increase the consent for vaccination of children in our national immunization programs. So our rationale for adult HPV vaccination, there is still a risk for new exposures. There is efficacy of vaccination at reducing disease. And as Elmar is going to show us, there is even value of vaccinating those who have previously been exposed. I am going to stop there and pass it back to you.
Nancy, thank you so much. And what a great introduction to Elmar. Just a natural process. Elmar, we look forward to your talk about HPV vaccination after treatment of disease.
Thank you for giving me the opportunity to talk on this topic. And it's seen by many people quite controversial, but I want to go through how the knowledge on this topic evolved. So this is my disclosure, and the problem we're talking about a high-risk population who has already proven to be susceptible for HPV. And it's more than 10 years ago that we got first data from post-hoc analysis from phase 3 vaccine trials. This was then confirmed by many other trials and meta-analysis of these trials, but now it is challenged by a negative randomized controlled trial, and there's even a second one which is not published yet. When we look at population-based data, these are data from the Netherlands, then we see that women after conization have an enormously increased risk for developing HPV-related cancer and the respective precursors. And when I had the opportunity to look into the database of the phase 3 trial of the quadrivalent vaccine. We were quite surprised to realize, in comparison to the placebo cohort, in those being vaccinated and treated for disease they already had at the beginning of the study, there was a marked reduction of future disease. So in general, it was a 46% reduction, and just looking at high-grade disease of the cervix, there was a 65% reduction. This has been then confirmed by the bivalent vaccine. So they did exactly the same what we did for the quadrivalent vaccine, and the efficacy was even better, 88% reduction of subsequent cervical disease in those women being vaccinated around conization. There was an Italian study run in Tuscany by Alessandro Ghelardi, and this was a prospective study, unfortunately not randomized, so women could choose whether they take the vaccine or not. And the results, however, were very similar. There was more than 80% reduction of subsequent disease in those being vaccinated, and on the right side of this slide you even see the HPV types causing those lesions. And since this was done with the quadrivalent vaccine, we would even expect better results with the 9-valent vaccine, because HPV-33 would be covered by that. There have been done various meta-analyses. I'm showing the last one available. And looking at all those studies, there was a consistent reduction of almost 70% of recurrent disease after conization in those being vaccinated compared to those not being vaccinated. And we are talking on more than 5,000 cases being vaccinated, with almost 18,000 not being vaccinated. So quite a massive body of evidence. This has again been confirmed by data published last year from Czech Republic. They have a centralized pathology analysis, and this made it possible to make this retrospective analysis. And they could also demonstrate that there is a highly significant reduction of recurrent and subsequent disease in women receiving vaccination after conization, and the results were even better when they had positive margins, which again was quite a surprise. Last October, we had the opportunity to publish the data of the 9-valent vaccine, and again we could demonstrate a 95% reduction of disease caused by the original 4 types and 86% of disease of the vulva, vagina and cervix caused by the 5 new types. And just looking at new infections with other types, this is on the lower part of this slide, you can see 100% of those cases of disease caused by new infections was prevented. So a huge body of evidence. However, critics always said we only believe it if there is a randomized controlled trial, and now we have this randomized controlled trial. The vaccine trial from the Netherlands, they had 2 years of follow-up, and they saw a non-significant difference of recurrent disease after vaccination compared to a placebo. So it actually was after 2 years 9% versus 6%. However, when we look at all the results they published, then we see a consistent reduction in all the parameters they investigated. It's cytologic abnormalities, histologic abnormalities, and repeat operations. So potential problems are the hypothesis for this prospective trial was quite optimistic. The numbers with 400 per group look quite okay, but maybe still too small. And what's more sensible is the duration of follow-up. With 2 years, it's quite short, but the authors told me they would follow up their cohort for up to 5 years, and we should be optimistic that this trial will reveal a significant result. What has been published since this trial has been published, there's another study register-based from Norway. They looked at HPV infections after conization, and they saw a reduction in HPV positivity, but what's most relevant, there was in those not being vaccinated 9.4% were HPV 16 positive and less than 6% in those being vaccinated, reaching statistical significance. And there were other remarkable data presented at the last IGCS in Cape Town at the end of last year. Those Italian authors looked into a US database, and they made matched pairs of more than 4,500 women, and in those not being vaccinated, they found 149 cases of invasive cancer after conization and only 96 cases in those being vaccinated, which would translate into a 36% reduction of invasive cancer. So this is not talking about infection, it's really talking about invasive cancer following conization. So summarizing the data we have today is we have data from 3 extensive high-quality phase 3 trial with pristine data collection, and the post hoc analysis was hypothesis driven. So for all 3 trials, the same hypothesis was applied. One point of criticism might be those patients in those trials, they were younger than they usually are for conization, which happens usually around the age of 35. We have a consistent confirmation through many other various trials, prospective, non-randomized, retrospective, register-based. However, we have now 1 negative randomized trial, and it will be followed by a second randomized trial. But the key thing is, since we have such ample evidence showing a benefit, and we have these in comparison rather small trials showing no benefit, we really have to dive into the details and try to understand why we see those differences in between those trials. And yes, I'm looking forward that we have the opportunity to discuss these findings. Thank you very much for your attention.
Well, thank you so much for that, and thank you to all the panelists for the excellent presentations. We move into a short Q&A, so I'm going to address some of the questions, and we have some in the chat who've actually gone there. Nancy, let me start with you, if I may. Men who have sex with men face elevated risk of HPV-related anal and oropharyngeal cancers. Are current programs adequately reaching this group, and what does good practice look like?
Yeah, I think this is a very important question, because if we only think of in the adult population of linking cervical screening and the offer to vaccinate, we will miss the whole population of men who have sex with men. So if we discuss it with a woman and encourage her partner or partners to also be vaccinated, those are only the people who are having sex with women. MSMs, we must also consider for vaccination. They're a high-risk group for HPV infections and disease. So those of us who see male patients should be discussing this. And where I live, we've even started to think beyond just the traditional healthcare provider visit, as many young, healthy males may not be seeking medical attention from, let's say, a physician or a nurse practitioner. So, who are some other healthcare professionals who could fill this gap? And we can look then to pharmacists for discussing vaccination. And in many regions, they are able to administer HPV vaccination. And in your world, also, Ram, we also are now looking to dentists, who are those who we see often once or twice a year, who look in our mouths, who screen us for oral cancer. We don't have screening for oral pharyngeal cancer, but dentists are a gateway to all individuals, including MSMs, and the dental community has been very encouraging about wanting to learn about education for HPV for patients and even prescribing HPV vaccination. So we really must meet the needs of the MSM population as well.
Nancy, thank you so much. Yes, and as a dentist, I can support that, and not only giving advice, but actually giving the vaccination as well. I often say that if we can find the lower inferior dental nerve, we can find the left arm. So that's Elmer, you sit at the intersection between the treatment and the prevention. What's the persistent misconceptions people have about vaccinating adults and also post-treatment?
The greatest misconception is that people think once they have contracted an HPV infection, and almost everyone has contracted an HPV infection, or once you reach the age of 25, that the vaccine doesn't help. And the data clearly show that you get a benefit and you prevent new infections at any age. And in Europe, we even don't have any upper age limit for the vaccination. So you can vaccinate at any age. The earlier, the better, but it's never too late. And the second misconception, and Nancy talked nicely about it, is the misconception that monogamous relationships protect you against new infections. So we know the opposite is the case, and 50% divorce rate we observe. And if my patients tell me I'm in a stable relationship, I say, well, wonderful, congratulations. I'm very happy for you, but you and I don't know if it will be the case in 5 years' time.
And I think that just like we want to vaccinate adolescents before sexual activity happens, in adults, it's the same thing. Let's say you knew that the relationship you're in is going to break down 10 years from now. We don't want to wait 10 years for you to be vaccinated. Until that activity happens. We want to protect you before that activity happens. So we want to vaccinate you now. And also, I do find healthcare providers do often think, especially with respect to women, that if they're in a stable relationship, they're never going to have another new partner ever again. And they just don't think that life happens and that people do have new partners.
Yeah.
Sure.
I
Thank
always
you
tell
so
my
much.
patients, I don't use the safety belt in my car because I want to have an accident today. I just take it in case it happens at some time in my life that I have an accident, then I want to have the safety belt. And it's the same with vaccination.
Good.
Thank you so much. If I may jump in, Raman, and say, yes, this is all about conception that even our colleagues have. I have clear evidence that clinical colleague here in close neighborhood in Lausanne discouraged a friend of mine with anal cancer to get a vaccination. You're too old, you have it already. And it's conception. And that's why I think it calls even more for public health to normalize it as a general thing you do without saying perhaps men having sex with men, perhaps younger girls, perhaps all these things are just our concepts. If we normalize vaccination and don't even talk about men, women, and old age, then I think we can get out of the conception thing.
Yeah.
Thank you. Sorry.
Thank you so much. Bettina, that was really encouraging. So let me just ask you, we have 140 members in our of national associations, public health associations, part of the World Federation. What advice, if there was something concrete advice you would give with regard to HPV adult immunization to those associations and their governments, what would it be?
Yeah. This because we are worldwide. Here we are with a European group. We are worldwide. And Nancy already showed the example of Rwanda. Again, a misconception. We think that people living in low income or low middle income countries will be underserved. The contrary may be the case if well organized in a country with restricted resources. If you start the program well from scratch, you may be more efficient and faster, but we really have to do it in a proper, efficient way. There are places in this world who have a very high burden, as shown by Nancy, and these are places without screening and without vaccination. So you have the possibility to start. So if you start, please learn from our, let's say, mistakes and implement a full program without splitting people into groups, without having misconceptions or gender-based views. Just do it in a proper way. And I think that low resource settings have the possibility to do even better than some of the places which have a bit too much money and have to protect all those who earn money.
Okay, that's really helpful. So, in conclusion, if I asked all the panelists now, if I gave you a magic wand, where would you actually want to wave it? What do you think is the single most thing that we could do to bring about adult immunization? Elma, let me start with you. You're muted, Elma, at the moment.
I think, especially as a gynecologist, we have so many chances of seeing women and counseling also women on their male partners. And especially when a woman comes for contraception, when a woman is going to be pregnant, then we can counsel her on the benefits of adult vaccination. And we also have to consider our life expectancy is enormously increasing. So people are going into their 90s, and even when you are 45, now you have another 50 years to live. This also should be considered. And so we should take any chance, any contact with our patients to counsel them correctly.
Thank you. Nancy, where would your magic wand be?
I think we need to look inwards to ourselves as healthcare providers, and we all should look at what are our own biases and recognize them. Because if we don't present information to patients, if we prejudge the patient and we decide who we're going to talk about this with and who we won't talk about it with, by risk stratifying in our own minds, we'll often be wrong because we may not know the risk that a patient has. So I think we need to really work as a provider to provide that information to the patient so they make that best informed decision for themselves.
Good. Bettina, where would you wave your wand?
My wand, I would take Nancy's and wave it not only to my medical health professional colleagues, they are definitely biased. I would wave it to the leaders and deciders at a political level because we are all struck with ageism. We all have misconceptions about age, and this goes through clinical colleagues, politicians, and everyone. The way you're progressing in age, you start to change it, but you have, as a decider, to be free of ageist thinking. That's why to get adult vaccination means think very openly about age and adulthood.
Good. Thank you very much. Look, it's been really fascinating, actually, and it's part of an ongoing conversation we're having at the World Federation of Public Health Associations and our call to action. And we're really grateful for ESGO's partnership today in co-organizing and implementing this program. So what really comes next? This is part of an ongoing conversation. We will have another side event at the World Health Assembly Week, and details will be available. And we also will have a World Leadership Dialogue at the World Congress of Public Health in Cape Town in September this year. So it's really a part of us all to take this conversation, as Nancy have said, take it more widely to our patients, to people we're involved with, to decision makers, because we have the evidence, we have the vaccine, and the call to action now is past the debate. It's really about implementation. I want to say thank you to all the speakers again for a wonderful presentation, and we look forward to further conversations, further promotions, and further implementations of adult immunization. Thank you so much.